This is week 13, molecular genetics and prenatal diagnosis. The learning objectives for this week are to give examples of diagnostic carrier detection, pre-symptomatic and predictive DNA testing, and the use of targeted multi-gene panels and whole exome sequencing. To identify and utilize genetic databases to identify genetic tests and interpret results. To discuss interpretation of genetic result variants as pathogenic, variant of uncertain significance, VUS, likely benign or benign, and to discuss counseling issues related to communication of risk, discussion of potential testing outcomes, and meaning of results. The identification of pathogenic mutations provides important options for the early detection and prevention of many serious and fatal genetic disorders. Today we see that the golden era of human genetics includes the utilization of preconception, prenatal, and pre-implantation genetic diagnoses. Every patient in every medical specialty should be viewed through the lens of their personal genome. And the analysis of DNA has increased the number of mutant genes that can be detected. And today the patient benefits with the available carrier detection tests, pre-symptomatic and predictive tests, and pre-implantation genetic diagnoses. Whole exome sequencing, WES, and whole genome sequencing, WGS, has provided useful information for genetic counseling and the ability to inform clinical management, as well as the ability to provide the information necessary for effective treatments. These two techniques have opened new avenues for targeted gene sequencing. They have helped with the discovery of new genes. Please go to the link for the video on WGS in Britain and to the link for a discussion of WES. I've also included in this module a presentation on explaining variants of uncertain significance, VUS, a guide for clinicians. I found a lot of things that they said in this article are important. I work, as I mentioned before, as a cancer geneticist, and every time you get a VUS, patients get a little nervous. So I follow what they say here. Before I even do the testing, before I do the informed consent, I explain that a VUS is possible. And we talk about human variation, and we talk about genes, and we talk about chromosomes, so that my patients then are going to be ready if there is a VUS. And with the panel testing that I do with the cancer genes, this happens very often. And I know that the physicians, when I write the letters, they don't like it. And they're very nervous when there's a VUS because they can't say to the patient, you either do or don't have, you're perfectly clear from having the specific gene. Now, also, there have been many times lately that I've been signing up the patients for family studies because the labs where they have been doing the testing have asked if they fit specific criteria that I have shown them in the pedigrees. They would like them to to enroll the patient to enroll in a family study. And I would say that 99.9% of the patients do enroll in these various testing. I will also say that there has been a few times in the past 5 years or so, 5 or 6 years, I've been doing that genetic testing for the cancer patients for the past 10. But for the past 5 years, I would say that saw more where VUSs were shown now to be pathogenic. And then we've had to call the patients back in, and we've looked to put them into a higher risk group. Also, I'm seeing more and more insurance companies require pre-counseling with a certified genetic counselor prior to testing for cancer gene testing. And I think this is because there was a lot of individuals who got upset when they had a VUS and it wasn't explained to them properly, or there was a lot of unnecessary testing that has been done by physicians, so that a genetic counselor is required. If we look at the commonly used databases in genetics, we see that for clinical databases, the Online Mendelian Inheritance of Men, OMIM, which is put out by the National Center for Biotechnology Information, can be seen at the link provided as well as a YouTube video on this specific database. Now, I want to take a moment just to talk a little bit about Victor McCusick because Victor McCusick is the individual who conceived and compiled the Mendelian Inheritance in Man, which was an annually updated catalog of human phenotypes, which was first published in 1966. And today it is published online. Now, Victor McCusick was a cardiologist, and today he's widely considered to be the founding father of medical genetics. He was an innovative clinician, a medical educator, and a researcher. He established the first medical genetics program and clinic at Johns Hopkins in 1957. What I think is interesting, and I think you will find the interview interesting, is when he talks about when he first started and some of the things that he did and how basically at that time nobody thought that genetics was important. But as a quote from Victor McCusick, he stated, "I became known as a cardiologist before I became known as a geneticist. Some thought I was committing professional suicide and leaving cardiology to focus on rare and unimportant genetic disorders. They asked me why I switched from cardiology to genetics. Actually, it was a matter of phasing down cardiology and ramping up genetics after 1957." And Victor McCusick died on July 22nd, 2008, at the age of 86. And here we have the link to the microarray gene expression databases. I've put two in here, the Stanford Microarray Database SMD and the Gene Expression Omnibus from the National Center for Biotechnology Information. Here are three databases concerned with genetic variation. The 1,000 Genomes database, and here you have the link to that database as well as a YouTube video on how to assess it. There is a link here for the genetic testing repository at the National Center for Biotechnology Information. And then there's also the clinically important variations, ClinVar, and you can see the link as well as a YouTube in how to assess ClinVar. ClinVar is a freely available public archive of human genetic variants and interpretation of their significance disease. And the National Institutes of Health maintains this specific database. Interpretations of the clinical significance of variants are submitted by clinical testing laboratories, research laboratories, expert panels, and other groups. And then what ClinVar does is it aggregates the data by variant, the disease pairs, and by variant or set of variants. And then the data is aggregated by variant, and they're accessible on the website. I included in this week's module a reading on some FAQs about genetic testing was put out by the National Human Genome Research Institute, and I just wanted you to read that over about the different types of testing. And I also just wanted to talk a little bit here now about the benefits and drawbacks of genetic testing. And when we look at the benefits, the genetic testing may be beneficial, whether the test identifies a mutation or not. And the reason for that is because for some people, the test results serve as a relief. It eliminates some of the uncertainty that they may have about their health. And the results may also help doctors make recommendations for treatment or monitoring. And in some cases, it also gives people more information for making decisions about their and their family's health, and allows them to take steps to lower his or her chances of developing a disease. So I want you to remember those things when you are doing your little presentations, and also just to remember that people may be screened earlier or more frequently. They may make changes to their diet, and it helps to make informed choices such as whether or not to have a baby. In looking over the drawbacks that are in this specific publication. Genetic testing generally has a low risk of negativity impacting an individual's physical health. However, and all of you now have been doing clinical, it can be difficult financially for some individuals or emotionally to find out the results. And the limitations of testing are that they cannot tell you everything you want to know about the genetic disease. You can't be for sure. For example, if you're doing some testing for various cancer genes. I would like to talk about the Peutz-Jeghers syndrome, PJS, which is an autosomal dominant disorder with a mutation on the STK11 gene, also known as the LKB1 gene, and it's located on chromosome 19 at the position P13.3. It is a tumor suppressor gene. Children who are born with Peutz-Jeghers syndrome often develop small dark colored spots on the lips, around and inside the mouth, near the eyes and nostrils, and around the anus. These spots may also occur on the hands and feet. They appear during childhood and often fade as the person gets older. Most individuals with PJS develop multiple polyps in the stomach and intestines during childhood or adolescence. And these polyps can cause health problems such as recurrent bowel obstructions, chronic bleeding, and abdominal pain. Individuals with PJS have a high risk of developing cancer due to these polyps. This happens during their lifetimes, and the cancers of the GI tract, pancreas, cervix, ovary, and breast are among the most commonly reported tumors. Now, the reason that I'm bringing in this syndrome at this specific time is because it was in 1947 that Dr. Victor McCusick took his first step into medical genetics when he saw a teenager with intestinal polyps and curious pigmented spots on his lips. Within 2 years, Dr. McCusick had seen 4 other patients with this combination, and 3 of them were in the same family. He thought this was a hereditary condition. Hearing that a Boston physician, Dr. Harold Yeagers, had seen 5 such cases, Dr. McCusick contacted him, and the two wrote up their cases for the New England Journal of Medicine. This became Dr. McCusick's first medical publication. Because the syndrome had been noted many years earlier by Dr. Pultz, a Dutch physician, it was later named the Peutz-Jeghers syndrome, PJS. And Dr. McCusick had been intrigued by genetics since taking a pre-med genetics course at Tufts and wondered if PJS was a case of genetic linkage. His mentor, Dr. Bentley Glass, persuaded him that pleomorphism, a single mutant gene causing diverse symptoms, was a more likely cause. Later research confirmed Dr. Glass's clinical intuition about PJS. This is a picture of a young child who has those darkly pigmented spots on his mouth associated with PJS. Something for you all to remember as you're learning your various syndromes. I did not cover this syndrome with you, but it may have been covered in one of your other courses. But anyway, I wanted to put it into here for a review. What syndrome am I? I'm a genetic condition characterized by kidney disease, renal loss, and hearing loss, and eye abnormalities. About 80% of cases are caused by mutations in the COL4A5 gene and are inherited in an X-linked pattern. Approximately 15% of cases results from mutations in both copies of the COL4A3 or COL4A4 gene and is inherited in an autosomal recessive pattern, and autosomal dominant inheritance is found in about 5% of cases. So I'm showing you this because of the different methods in which things are inherited, because this can become difficult when you are looking at someone's pedigree without doing the specific genetic testing. So this is Alport syndrome. This is hereditary nephritis or Alport syndrome. You have the kidney abnormality associated with the deafness and the visual abnormalities. So what syndrome am I? I have an autosomal dominant inheritance pattern. Almost all cases result from mutations in the gene I have craniosynostosis, syndactylia. I cause a sunken appearance in the middle of the face, bulging and wide set eyes, a beak nose, and an underdeveloped upper jaw, leading to crowded teeth and other dental problems. And I am Apert's syndrome. What syndrome am I? I cause craniosynostosis. I cause wide set bulging eyes and vision problems caused by shallow eye sockets. I cause strabismus. I cause a beak nose, underdeveloped upper jaw, sometimes a cleft lip and or palate, and I'm inherited in an autosomal dominant manner. And I am Crouzon syndrome, or Crouzon's disease. You can see the skull shape, the eyes, the midface, nose, and teeth, the palate, lips, ears, and is distinguished from other similar syndromes by lack of hand and foot deformities. And that's one of the things that I want you to take away from this. There are, even though there is the craniosynostosis, there is no syndactylia. There is no hand or foot deformities.